Hello friends. Today we are going to discuss about post-traumatic stress disorder. Often, in short term, it is called as PTSD. I am Dr. Suresh Badadbhat, Professor of Psychiatry, working at NIMANS, Bangalore. Before I start my presentation, I would like to place a disclaimer. This presentation is for academic and training purpose only. If you want to have a clinical opinion, please do contact a psychiatrist. How to do the assessment of PTSD? Assessment of PTSD should start with the screening. Screening with the two important questions. The two questions which need to be asked is, does this client had experienced trauma in the recent past? Or else, does this client is at this time warrants further assessment with regard to trauma related symptoms? These are the two things you should to ask yourself and explore. At the same time, you need to know what time you are assessing the trauma. Is it within 1 month or else the trauma was long back? So these are the assessment points has to be considered. Along with that, assessment need to focus on the trauma history, intensity, frequency, dosage of trauma, loss, death of a family member, friend, meaning of the trauma and futuristic trauma, whether he is believing that the trauma will reoccur. Past history of trauma, at the same time past history of medical condition, mental disorder, risk of self-harm, suicide, and violence need to be considered, along with personality history, past coping style, present history of mental illness and substance use, social and family support, availability of resources and economic support is very essential to deal with PTSD. At the same time, you can use this PTSD checklist, Wither et al. 1993 is available in public domain, to monitor the symptoms and how much he is scoring in every follow-up. And continuous assessment is essential to know the progress of treatment, because the PTSD treatment will be very long. And regular assessment at least once in a month, sometime 2 months once is required. Regular rating of the severity, know whether the patient is improving or else symptoms are worsening. That needs to be checked. And check for comorbidity. Check the comorbidity, not only checked at the baseline assessment, because comorbidity can be occurring even in the later part of the PTSD. The PTSD would have diagnosed 1 year back. Depression may be triggered now. That means PTSD along with comorbidity should be checked in every follow-up. Every doctor and mental health professional should avoid re-traumatization. Re-traumatization means, imagine a client who have undergone sexual assault, that is rape. That is the primary trauma. And when the person comes to the hospital, you need to be very careful. You should do not do re-traumatization. That means you should be very careful about secondary victimization. Respect the client's emotion and behavior, because the person is under severe anxiety, severe trauma, and severe emotional response, and they may behave erratically. Never ever comment about their behavior. Be sensitive about the client's history. Do not avoid prejudice. That is very essential. Do not comment on the patient's character, coping skills, lifestyle, dressing style, family, gender preference and orientation, because commenting all this will cause again trauma, that is secondary trauma, and you should, being a health professional, should not do secondary trauma. Coming to the treatment of PTSD. The treatment of PTSD can be two. Either it may be psychotherapy or medication. United States FDA has recognized these are the medicines. That is SSRIs such as paroxetine, sertraline and fluoxetine. SNRI like venlafaxine has been, and NASA metrazapine has been approved. Decimipramine, phenelzine has been also been approved. Antipsychotic like risperidone, quetiapine, prozosine, alprazolam and clonazepam. These are the drugs have been approved for PTSD. However, there are various studies which talk about various other SSRIs and also various SNRIs, TCAs, MAO inhibitors and various other medications. And these treatment guidelines are available, including APA guideline is available, and also DJ Stein 2009 has done a good review with regard to treatment guidelines. However, SSRI remains the first line of treatment with regard to PTSD, especially in India, because the availability of the mental health professional for addressing PTSD is very essential. And other drugs which can be used in PTSD are citalopram, escitalopram, clomipramine, imipramine, desipramine, amitriptyline, fluoxamine, olanzapine, cortisol, and topiramate has been tried. In certain cases, propranolol has also been tried, that is beta blockers. Moving to the adequate trial. Before you change the medication, at least give an adequate trial with adequate dosage 4 to 6 weeks. The adequate dosage is antidepressant dosage. If the patient responds, increase the dosage to the OCD related dosage. For example, antidepressant dosage for fluoxetine is 20 to 40 mg, whereas in OCD it is 60 to 80 mg. If a patient is responding to PTSD and the dosage is around 40 mg, do not hesitate to increase it to 80 mg, because sometimes in PTSD higher dosage is also been recommended. But however, these are all few case reports and open label trial. Augmentation also can be carried out, especially if the patient responds partially for the first line of treatment. And also, please remember, there is a poor compliance for both therapy and medication in PTSD, because they do not want to call themselves as a person with mental illness. They feel they are the victim of trauma. Hence, many a time they do not take medication or do not engage in therapy. Explore the comorbidity. This is very essential, because 70% of the patient with PTSD has one more psychiatric diagnosis. Hence, you need to address the comorbidity, and many times combining the treatment is very essential. Moving to psychotherapy in PTSD. There are various therapies have been explored in PTSD. The commonest is exposure therapy. Along with exposure therapy, cognitive therapy has been tried. Cognitive therapy along with cognitive restructuring has been tried, along with EMDR, that is eye movement desensitization and reprocessing therapy, along with supportive counseling, and also problem-centered therapy and treatment as usual has been tried. If you look at this chart, here the maximum response is given and seen, and also the range has been given there. If it is near to 10, that means it has a good evidence. Especially exposure therapy along with cognitive therapy, and cognitive therapy and exposure have highest response. That means CBT is the best treatment for PTSD. Although the other response along with EMDR also comes closer, but CBT, that is cognitive behavioral therapy for PTSD, is approved and accepted scientifically. Moving to the prevention of PTSD. Imagine there is a disaster or else terrorist attack. There have been many people have been exposed to this traumatic event. Can we prevent PTSD in the population who have been exposed to severe trauma, or else in a place of natural disaster? There has an earthquake or a flash flood has occurred. Can we prevent PTSD in the population who has been exposed to the trauma? There has been various studies, but however, none of the medications have been approved for prevention. At the same time, there have been promising results, especially with regard to cortisol, propranolol, and citalopram has been there. But however, there is a need for RCT. But especially in traumatic event, doing RCT becomes highly unethical. But however, for scientific temperament, we need to venture into these studies. Coming to the course and outcome of PTSD. This is very, very contentious, at the same time very debated subject. Moving to the PTSD course and outcome. The course and outcome is directly dependent upon the traumatic event, time of assessment, what type of diagnostic criteria you are using, either ICD or DSM. At the same time, the experience of the mental health professionals matters the most. If you are doing assessment immediately after the 1 week of the trauma, 95% of them will qualify for PTSD. But however, in DSM-5, it is 1 month minimum is required. Hence, within 1 week, there will be 95% qualifying except for the duration. But within 1 month, the symptom reduce and becomes 60%. By 3 months, it is 45%. By 6 months, it is 40%. Various course and outcome studies, which I have done for 7 to 8 years, clearly said that half of the individuals by the end of 3 years will remit. That means 50% of them within 3 years will remit with or without medication. But however, if the person is untreated and there is a delayed onset of PTSD symptoms as a poor outcome and poor prognosis. That means if the symptoms starts after 5 months after the traumatic event, that means he has a poor prognosis and poor outcome. And at the same time, PTSD following exposure to a natural disaster, the highest mean of remission rate is 60%. Here, the people will give a meaning for a natural disaster, telling that everybody is affected and the nature was the person to blame. With regard to various other medical related or else human related disaster or trauma, the remission rates decreases to 30%. Especially the studies done and meta-analysis clearly said that physical diseases related had a lowest remission rate. Moving to the course and outcome, the important points to be remembered is early diagnosis and treatment along with psychotherapy has a good outcome. Delayed onset or a chronic onset has a poor outcome. Let's understand various predictors of the outcome of PTSD. The robust predictors have been very important or true. One is comorbidity along with PTSD, poor family support and poor social support had a poor outcome. Comorbidity like substance abuse, depression, anxiety disorders, personality disorders like schizotypal, borderline PD and also OCPD had a poor outcome. But however, modest predictors with regard to our trauma, especially man-made trauma, dosage of trauma and the repeated trauma have been considered. At the same time, childhood abuse also is considered as a poor outcome for PTSD. Minority group with poor financial support has a poor outcome. Delayed onset and longer duration of illness also has a poor outcome. To conclude, my dear friends, PTSD is a multifactorial, polygenetic, involving vulnerable factors exposed to severe trauma with past exposure characteristics and environmental factors impacting the brain, leading to PTSD in few individuals. Not in all. The PTSD symptoms will resolve in many of them within 1 month. But if it persists after 1 month, you need to diagnose PTSD and treatment should be initiated. PTSD is present in all culture, across the country, across the continent. It can be easily diagnosed by using DSM-5. But by ICD-10 or 11 criteria, the PTSD diagnosis decreases in prevalence. Whereas with the DSM-5, accuracy, validity, reliability is easy. Hence, DSM-5 is considered as one of the robust mechanism for diagnosing for PTSD. But remember, PTSD is a biological construct. Although trauma plays a role, the genetic vulnerability plays a very essential role. Hence, it is a biological construct. Early diagnosis and treatment is a must for PTSD. Medication or CBT can be considered as the first line of treatment in PTSD. In India, the availability of the treatment matters the most. The trained psychologists for trauma CBT are very less. Hence, medication remains the first line of treatment. In medication, SSRIs are the first line of treatment. And remember, 50% of them remit by the end of 3 years. But however, in remaining 50%, explore for the comorbidity and treat the comorbidity aggressively. And again, remember, treatments need to be taken for many years. Do not stop medication. And PTSD patients are known to stop medication, telling that they are the victims of the trauma and they are not mentally ill. You need to do psychoeducation for the person who are suffering from PTSD and family members. Because of the traumatic event, there are brain changes. Those brain changes need to be reversed either by medication or therapy. And treatment is very essential, my dear friends. Thank you for giving your valuable time. Stay safe.